the placental attachment to the umbilical vein. You can see it's a 3 millimeter diameter of the umbilical vein, and you got to get your needle precisely into the umbilical vein. If not, you will extravasate the blood. Either you will not be effective, or you might kill the baby if there is a extravasation into the Wharton's jelly. So it requires an extreme control of eye hand probe movements, but it is highly rewarding. Although I keep telling, my life expectancy comes down 1 year every time I transfuse. But as I said, it is quite rewarding. And this baby went on to term after 6 transfusions. And baby stayed in neonatal unit for 5 days and went home without any problem. So this is quite rewarding. And every year they send me card, and now he is about 9 years. So last one was 5 years ago. They stopped. Wonderful. So fetal medicine. Okay. So fetal medicine as such is usually a diagnostic, but interventions are catching up. There are many areas where we can do a difference to the fetuses, on difference to so many people. So interventions part is, although it's small, but it is growing. Why? Mainly because the technology of the ultrasound is, as all of you know, is growing very fast, and sometimes I feel it hit the height of resolution. But every time you see a newer machine, there is something new. There is something amazing. Although it is cost is high, but the advances are unbelievable. So because of that, we are able to see the fetus in much more detail. We can understand the fetus much more than what we used to do in the past. I remember Emerson's, Ralph Waldo Emerson is a Russian novelist, beautifully said, people only see what they are prepared to see. If you want to see, you will see. So this is where all innovation started. I'm going to play one video. This is the real future.
To engage with a 3D image literally. Really crop the hologram to define a desired plane, giving me comprehensive from any angle. Rotated. You can mark a point or drop technology intervention.
This is a hologram where you have a touch feeling also. This is about 10 years ago, started presenting about the future of fetal intervention. 10 years, I thought it will be available in another 1 or 2 years. It is still not in reality, but it will happen in near future. So we've got to wait for that technologies to come. And in terms of ultrasound performance, whether we can use robo. So I've tried this robo to see why we should sit in front of the computer and physically have to do ultrasound. If you can get the robotic arm and you get the control and you can play it around and make it happen, it is a wonderful thought. But since last 10 years I'm trying, it is not progressing. I don't know, one day we will have robotic arms to do our ultrasound. So a little bit about future. I don't want to spend much time. I don't have so much of time to go through future. In future, we will have a gene therapy. This gene therapy also, about 15 years ago, Jennifer Doudna, when she discovered gene editing, CRISPR, I thought it will be available in by 2020, but we've gone past 2020, 2025. Maybe in another few years, we will have some gene therapies, and I'll come back after a few years to give you any update on gene therapy. I'm sure it will be an exciting one. Fetal surgery, many people are doing, but in an Indian setting with our ecosystem, probably economically it is easier to make another baby than having fiddling with an abnormal fetus. That's the general public view. So that again we will have some other day. Now we'll concentrate on what we can do in today's time. So there are several interventions grouped into FIGS, that is fetal image guided procedures, endoscopic procedures called FITENDO. These are all American nice acronyms. We can do open fetal surgery, which is obsolete. We can do minimally invasive fetal surgeries and hybrid in between in utero and ex utero. We can do exit therapy. Under image guided procedures, there are several procedures we can do: direct fetal drug delivery, selective fetal reductions, intrauterine transfusion shunt, bipolar, radio frequency ablation, and by fetoscopic laser photocoagulation, and a fetal endotracheal endoluminal tracheal occlusion. There are so many further advances are happening. I'm going to give you examples of all these procedures, and as I said, I will take you through real life scenarios, so it will be a little bit interesting. So as all of us can understand, any subspecialty or a super specialty is a teamwork. You need multiple people in your team, and all of us work in tandem and together make things happen, and we can transform lives. Whom we can, or how do we transform lives? We can transform lives of fetuses, twins, co-twins, and mothers' lives, society, and from medical fraternity. How do we change the lives of obstetricians, neonatologists, and finally the trainees? So I'll take you through each one of them. First, we look at twins. This is a little bit troublesome, and in twins, dichorionics are not that troublesome. Of course, they are troublesome, but monochorionics are a killer. So monochorionics, there are several complications attributable to monochorionicity. That's your TTTS, TAPS, TRAP, SIUGR, cord entanglement, and conjoined twins. All these abnormal complications of monochorionic twins or because of vascular anastomosis. 100% of the monochorionic pregnancies will have vascular anastomosis, but not all of them will have problems. But around 30 to 40% of the monochorionics will have complications like TAPS, TTTS, SIUGR. So out of 100 monochorionics, you probably will have 60 take-home rate. That means around 30 to 40% of them will have problems. So one such problem is a TTTS. TTTS, I don't need to go into the theory. The placenta, which is shared by these two babies, will have anastomosis. This anastomosis,
the circulation of the two fetuses. They are visible on the surface of the placenta and are called anastomosis.
So this anastomosis will majority of the time maintain the hemodynamic milieu of each fetuses, but at times there can be imbalance and one or both babies may be in trouble. So one case we followed from 23 weeks onwards, but when we get into 28 weeks, there was severe TTTS with a reversal flow in the donor, in the umbilical artery, and a reversal of A waves in the ductus venosus in the recipient. So this is a stage where we had to intervene, otherwise we would lose both babies. I'll play 1 minute video again. This is a laser under local anesthesia. We took her to theater because we needed a nice aseptic environment. Nowadays, we don't need to take her to theater. We will do it in outpatient. So this is a vascular dilator, 10 French. Seldinger technique, we're going to get into the amniotic cavity, and then we pass a fetoscope. In the fetoscope, we visualize a fetus. We don't need to visualize, but we visualize the abnormal vascular anastomosis and selectively burn them. So there may be 5 or 6 abnormal connections. This requires a lot of experience, and brick heart, and an extreme dexterity. So we identify the abnormal connections, we burn them using a laser laser energy. And then, so this patient went on to 34 weeks, about 6 weeks we got, and then we delivered. I don't think I need to show you the delivery. After delivery, we saw,
Son.
I think this is better. Am I audible? Must be.
Yes, you are audible.
Yes.
So we tried and demonstrated where the anastomosis were there and how, whether laser completely coagulated the abnormal anastomosis. There was one recurrence, so that's why the baby started manifesting with recurrence of the TTTS. Then that's why we had to deliver. So you could nicely demonstrate all the anastomosis. Baby stayed in neonatal unit for 1.5 weeks and then went home. Such a nice thing. So that's when we can save both babies. Sometimes if you have an abnormal fetus in a monochorionic pregnancy, which carries a severe morbidity, like this fetus is got a dandy walker, it's a monochorionic pregnancy. If you leave it alone, this baby will not die, but survive with a lot of morbidity. So that's why we may want to stop this pregnancy rather than continuing. So this kind of situation, what we can do, we can do something called cord coagulation, where we pause a coagulator under ultrasound guidance and then catch hold of the cord and use bipolar diathermy and pass electricity and coagulate the cord. So it looks so simple if somebody is doing, but if you are doing, it is a little bit daunting, and it's not that easy. It looks so easy. Okay, I'll show you how it is done in another case. Another complications of monochorionic is a SIUGR. This is a type 3 SIUGR. Is particularly troublesome and difficult to manage. So this baby has got alternating absent present diastolic flow. That means this baby is surviving because of the help of a donor. If the donor doesn't supply blood, it will become IUD. And if it becomes IUD, the other fetus also will get into trouble. So we need to specifically identify these types of selective IUGR. And if there are certain criteria, I don't want to go into detail. And if it is appropriate, we try and stop this baby electively. Otherwise, if it stops suddenly, which can happen in about 15 to 20% of the time, not only that baby dies, the other baby also get into trouble in about 35% of the time. So that's why it is very difficult to watch this kind of IUGRs. So what we can do, I'll show you what we did for this one case. So this is a cord coagulation. These are about 2 minutes video I want you to watch. So it's a simple setup. You need a trocar, you need a coagulator, you need a diathermy, and it is done in as an outpatient. I used to do it in theater in the past, but you don't need to do in theater because it adds to the cost for the patient, and you're not going to get anything more because it's only about 3 millimeter incision. You can do it under local anesthesia. You don't need a general anesthesia or a regional anesthesia. More importantly, in India, we do vocal anesthesia. Tell them that nothing will happen, and somebody to hold their hand, then we can do it. So it's not that difficult. If you are a gynecologist, especially if you are used to do laparoscopics, this will be like another laparoscopy. Only thing is, in this fetus, there was no polyhydramnios. If there is no polyhydramnios, there is no pressure. So getting a trocar in can be a little bit difficult, but you could negotiate. We managed to do with a little bit of difficulty to get into the sac. I'll let you watch. once you get into the amniotic cavity, is not much difficult. And as I said, of course, it requires a little bit of dexterity, extreme control on your probe and your hand movements. But few cases, if you do, you get better, like anything in life. So that's the coagulator. Once the coagulator goes in, I'm pushing the baby to get my position appropriate, identifying the cord. And once you catch hold of the cord, it's easier. You just occlude the cord and pass electricity, and you can coagulate. You can coagulate 2 or 3 places to make sure that they will not recanalize, revascularize, and then you come off. So, and you don't need a skin suture also. It's a 3 millimeter. So what happened? Anyway, I missed one slide. That's okay. So that's about cord coagulation. We went on to term and then we delivered. Some of the slide is missing. That's okay. So the next type of complications in monochorionic is your trap. Trap is rare. Twin reverse arterial perfusion. I don't want to go into the details of the theory. You have one baby which does not develop heart and brain. This baby will supply the blood to the other one. Eventually, both fetuses will get into trouble. So what we can do, we can try and stop the blood circulation to this abnormal trap fetus so that the donor need not work hard to make this also survive. Anyway, this is useless fetus. So there are several options available when you see a trap. Either you do a cord coagulation or do a interstitial laser, or you can do radiofrequency ablation. Depending upon the case, you can choose whichever you want. So we did radiofrequency ablation. Again, I'll let you watch this 1-minute video. This is again as an outpatient procedure. Under local, a small nick is given, and you use a special radiofrequency needle. This is bloody expensive, 86,000 for this needle and about 30,000 rental for the machine, for the radiofrequency generator. So this is a pencil tip. You can adjust the active part of the needle depending upon the size of the area you want to burn. This is like any other fetal reduction. You just pass the needle and get this needle under the umbilical insertion and try and coagulate the area under the umbilicus where both umbilical arteries and umbilical vein would be coagulated. So this will cut off the road for the donor to donate blood into this one, and this will eventually become smaller and disappear. The donor will live happily ever after. So this one, after this one, we did a TV program. I mean, I didn't want to do a TV program. TV people came and made one TV program, which is about half an hour, little bit horrible TV program. But from that TV program, I started attracting all the monsters. And finally, this is about 2 years ago, we had traps, 16 traps, which is a very huge number in terms of whole world literature. If you see, the highest series will be around 11, 15. So we have more than that. And unfortunately, about 90% success. And that is really very rewarding. Okay, that's about monochorionicity. How do we transform the lives of a co-twin? We'll see a few examples. This is one long time, about 9 years ago. One of the twins of a dichorionic pregnancy had multiple problems. Don't want to go into the story. what we did, if you let it alone, let it live, this baby would be born with a lot of problems. So what we did is selectively stop that fetus, and it is stopping a dichorionic pregnancy is not that difficult because they are not vascularly connected. So we can try and inject KCL into the thorax and stop this baby, which should not cause any problem to the other fetus. Of course, there is a procedure related risk of miscarriage, but this is much less than the radio frequency or cord coagulation, which because of the increased size of the bore of the entry, the risk of miscarriage is higher in that one. So in dichorionic pregnancies, the risk is not that high, around 1 to 3%. So this mother was very happy. So multiple pregnancies, fortunately, are not that many, but because of the fertility treatment, it is more than digestible. But because of the strict guidelines with the IVF, the number of higher order pregnancies beyond triplets are not that common. So I can show you a few cases. So this is one of the triplets, trichorionic triplets. So it is a good triplets to play around, because again, trichorionic, we can stop one fetus if necessary without interfering with the other two. So this fetus, one of the fetus had increased nuchal. This is the reason why we do not want to do fetal reduction before NT scan, because if you have an abnormal fetus at NT scan, you can selectively try and stop that one. If you did stop before NT scan, you don't know whether you stopped a normal baby or an abnormal baby. By statistic alone, you have about 7 to 10% chance of one of the baby being abnormal. So it's better we do anatomical evaluation as much as possible and choose an abnormal baby if there is an abnormality. If there is no abnormality, then we can try and choose a fetus which is technically easier, that is away from the cervix and closer to your probe, closer to your abdomen, closer to your side. Then you can choose that fetus. And as I said, stopping a triplet pregnancy and a trichorionic, it is not that difficult. All you need to do is to get the needle into the thorax and inject a chemical, whether it's a potassium chloride or a lignocaine or even amniotic fluid or saline also can do it. And sometimes you can mechanically damage the heart and stop that heart. But if you have a difficult triplet, for example, this is a dichorionic triamniotic gestation, then it is little bit difficult, because would you stop this monochorionic pair, or would you stop a singleton continuum monochorionic pair, or stop one of the monochorionic twain? It's all depends upon what patient wants. Medically speaking, stopping this singleton and continuing with a monochorionic pair has got a highest pregnancy complications, because monochorionicity, or 30 to 40% of the monochorionic pregnancies will have some form of abnormal pregnancy outcomes. So you do not want to stop this one and continue these two. So can you stop one of this one and continue these two? Again, you need either a radio frequency or a bipolar cord coagulation, which carries a higher risk of miscarriage. So that's why you do not want to stop this one or one of this one. You may want to stop both of monochorionic pair by a simple KCL injection. So that carries the best pregnancy outcome. More complications. So this is one of the triplets where the placenta was only one. This is a monochorionic triamniotic gestation, which is a little bit rare. And logically, you may think that this should not happen or this cannot happen. But especially in a zona pellucida treated pregnancies, it can split. And one baby is split into two, and another one is split again. So you may get monochorionic triamniotic, monochorionic quadriamniotic pregnancies are also reported. So again, you have a monochorionicity, you got a triplet, is a double whammy. So complications rates are very high. So we wanted to try and stop one of these fetus, but this patient did not want any intervention. And unfortunately, she went on to 17 weeks and aborted all 3. So next, one more we had monochorionic triamnionitic. That patient, I insisted or I counseled more in favor of doing a fetal reduction. Again, IVF pregnancy. So that pregnancy, we did radio frequency ablation, and unfortunately, we lost this pregnancy as well. And in the beginning, this losing pregnancies will hurt, but gradually we need to get consolation in ourselves, because if you didn't do anything, the possibility of losing pregnancy or probability of losing pregnancy is higher. So 0 is your baseline. Anything more is a bonus. That's how we survive. So higher order pregnancy, fortunately, there are not many, but we still get some cases. So this is a quadruplet, and this is a Nigerian lady. There is an interesting story. I don't want to complete the story. Anyway, this pregnancy, she wanted only 1, and she wanted me to stop the 3. I forced her. She was a BMI of at least twice my size. So I said, it's not good. First, it is technically difficult, and next, if you try and stop 3 out of 4, the risk of miscarriage is in the range of 30 to 40%. So I did not want to stop all the 3. We managed to convince her to have 2 reductions and continue twin. And then, because she was a BMI of nearly 50, huge lady, we managed to get fetal reduction, 2 of them. And when I pulled the needle out, I was so surprised to see the needle was bent about 90 degrees. I don't know how I managed to stop these 2. And she went on to term and delivered. Nice lady, and she still calls me. Wonderful. So this is more. It is too many. She had 7 septuplets. Septuplets is too many. Don't want to get into this. This is extuplets. Again, there is a lot of stories behind all these cases. And this one, about 9 years ago, I managed to reduce 4 out of 6, and that was a lucky day for me. I managed to stop 4 in single pass. So I never expected that with a single pass I could manage to get 4 babies. I got 1. I said, why don't I get in the same needle the other one? I managed to get 2. Then I was pushing myself and managed to get 3. Also, I got the 4. So unbelievable. So all 4 in one go. And she went to term and delivered twins. And she did not even disclose to her gynecologist she had a fetal reduction. She went to her native place in Kerala in 3rd trimester, and nobody knew she had a fetal reduction. Amazing. So this is septuplets, and this septuplets is not because of IVF. It is because of the ovulation induction. So nobody transferred 7. I hope nobody does that one. So ovulation induction, hyperstimulation, and also hyperstimulation we should stop. But this lady escaped, and she had all 7. So again, we had a debate whether to do 2 or 3 in a setting. Finally, I said, no, nothing doing. If you lose a pregnancy, lose a pregnancy. And I stopped 5, and 2 were continued. She went on to term. So there are a lot of stories. So by fetal reduction, we are not taking away lives. We are enriching the life of the surviving ones. Okay, so about half an hour. So I have one more. I have about 20 minutes, ma'am.
Yes, about 15
Yes,
minutes.
Adi. Yes. It's okay. Very
Okay, you
nice
can
to-
I
continue.
have 20 minutes, sir.
Yes. Very nicely it's come.
Interesting. You can continue, I think.
Okay. I mean, if nobody is objecting, I'm continuing.
Yeah.
Okay. So we will see how we've. This is about twins and co-twins, which is a little bit difficult area. So in terms of fetus, how can we make a difference to the life of a fetus? there are certain conditions where we can deliver the drug directly into the fetus and make the fetus life better. One condition is SVT, supraventricular tachycardia. This is a 26-weeker with the signs of high drops. There were fluid in the lung, cardiomegaly, ascites, huge heart. There is a tricuspid regurgitation. This baby was dying. So we didn't have time to give the medications to the mother and then expecting the drug to go into the fetus and act. In this case, we primed the mother with a digoxin for a day, and then we gave intra-fetal therapy. Intrafetal therapy, this digoxin directly into the fetus. So we went into the intrahepatic portion of the umbilical vein. Digoxin delivered directly into the venous system of the fetus. In 3 days, converted into sinus rhythm. Tricuspid regurgitation was still there. Cardiomegaly was still there. This is about 10 days, I think. 10 days later, it was looking like a different baby. The fluid disappeared from the abdomen. Pleural effusion almost disappeared. Heart was beating nice and smooth and easy. And then she went on to 36 weeks and delivered. I'll skip this case. Again, another case where we delivered the digoxin into the placental insertion. This was relatively easier compared to the other baby because the placenta was anterior. We could access the umbilical vein through transplacentally, and we managed to deliver the digoxin. Sometimes there is fluid collected in the serous cavity, which can hurt the baby. We may want to drain the fluid if there is a mechanical implications. So this baby had a severe ascites. We don't know what was the reason for ascites. This was causing the splinting of diaphragm and causing pulmonary hyperplasia. So we put a needle and drained, and it did not come back. Amazing. So this baby is happier. So all we needed to do is to drain a little bit of LICAR. So this is another interesting case, which is a very desperate pregnancy, married life for 8 years, lost a previous baby, and at 18 weeks had a pleural effusion. We didn't know what was the reason. We waited for 2 weeks, and the pleural effusion did not disappear. So they wanted me to do something, and I said, look, I can't do anything. We can drain the fluid and see whether it will help. We did drain the LICAR, drain the pleural effusion, and waited for 2 weeks. But unfortunately, it came back after 2 weeks. Then, as I said, it was because of a desperate pregnancy. We put in a shunt. This is the pleuroamniotic shunt. A very difficult case because the placenta was anterior, so there was no access to get in. But fortunately, we got the shunt in, which is a nerve-wracking procedure, and unfortunately, we lost this pregnancy. So as I said earlier, when we lose pregnancy, all we can do is take some consolation, saying that we have done our duty. Somebody upstairs has to look after. Not all pregnancies we lose. This is one interesting 27 weeks, 6 days, had a massive unilateral pleural effusion. And then again, the same mantra, we thought we will get better by just draining this fluid rather than putting a shunt, because putting a shunt increases the risk of miscarriage. So we don't want to lose pregnancies. And many of the pleural effusions will disappear once you drain. Don't know why. Most likely because of the lymphatic blockage, and change in the pressure dynamics may help the lymphatics to open up, and then you don't get the pleural effusion. So we did drain, and then expecting that it wouldn't come back, but 2 weeks later it came back with vengeance. Same amount of pleural effusion, so we had to do shunting. This justifies putting a shunt. Otherwise, putting a shunt straight away because of the increased risk of miscarriage, it is not justifiable. In this case, there was no other way we can help the fetus other than putting a shunt. So shunts are rare. Indications are very few. Only in pleural effusion or certain kinds of pleural effusion, unresolving one, we can put a shunt. Other areas, the shunt is almost become obsolete. So I will rush it. So we put one part of the Harrison shunt into the thoracic cavity and leave the other into the amniotic cavity, hoping that this fluid is drained by the shunt into the amniotic and lungs expanding. Many times it doesn't work because the shunt may get blocked because of the vernix, because of the debris. Sometimes it can come out, come inside, go inside, or babies can pull it out. So babies can do all sorts of things. So that's why you have to put the shunt at the back. If you put the shunt in front, when it irritates, babies can pull it out. So this baby, we fortunately managed to get into the subscapular region. One loop inside and 2 loops outside. And then the pleural effusion did not come back. Baby went on in the neonatal period happily and had only one drainage. And because of the change in the diet, pleural effusion did not come back. This is a chylothorax. This is another interesting long story. Don't want to go into the story. This is a pericardial effusion. Pericardial effusion, we don't know what to do. And many pericardial effusions will disappear. This baby had a small ventricular diverticulum that was irritating the peritoneal pericardial cavity and having a massive pericardial effusion. And some pericardial effusion, as I said, will disappear. This did not disappear, and it also showed evidence of cardiac strain in terms of absent A waves and a massive tricuspid regurgitation. We debated whether to do anything or not. Finally, patient wanted us to do something. Otherwise, we may lose a pregnancy. So what we did, after waiting 2.5 weeks, it was increasing and it was not resolving whatsoever. And finally, we decided to put in a needle. Keeping the needle next to the heart, it requires a lot of guts. So we managed to drive this pericardial effusion, and then it did not come back. Unbelievable. Then she went on to term and have a nice baby. I don't know whether still have time. I have few more cases. Sir, what to do, sir? Shall I show you a few more cases or shall I stop?
Yeah, you can do.
Ma'am?
Dr. Adi, you can continue. Dr. Adi,
Adi, continue.
hello, continue.
Adi,
Please continue.
sir, ಹೇಳಿದ್ದಾರೆ. Madam,
I can't hear him.
You can't hear? Please continue.
continue.
These are all rare.
Continue ಮಾಡ್ಬೋದು, sir.
Not audible, ma'am.
Continue. You can continue. Oh God.
ಆದಿ ಕೇಳಿಸ್ತಾ ಇದೆಯಾ? ಕೇಳಿಸ್ತಾ ಇಲ್ಲ ಅನ್ಸುತ್ತೆ ಅವ್ರಿಗೆ.
ಕೇಳಿಸ್ತಾ ಇಲ್ಲ correct.
ಆದಿ
Okay.
is
You
not-
can continue, Adi.
You can continue.
Can you hear us?
Please continue.
Oh, yes.
You can see me, no?
Oh, yeah, yeah.
Continue.
Now I can
Yeah.
hear, madam. Okay. Okay, okay. Good. This is another giant chorioangioma. This was causing vascular or volume overload to the fetus. And also, this is a hugely vascular tumor. Because of the third space, it was using a lot of platelets and also causing anemia. So this is a difficult case. Now you have a volume overload and also anemia. Now, which one to treat? What do you treat? Or treat both together? It was a little bit difficult. Doing an intrauterine transfusion because baby was anemic with the MCA VMX as sky high, and also cardiomegaly and a heart strain was there. If you don't do anything, you lose this pregnancy. There is no question asked. So what we did, instead of doing two procedures together, we did do a laser because that was a killer for this baby. So we did a laser, interstitial laser, and we ablated we made it tumor avascular. So once we did that one, we can look at this. So previously it was hugely vascular. I think I have an image. Anyway, after the laser, it became completely avascular. And then a week later, baby was still anemic. Cardiomegaly was coming down, but baby was still anemic. So then we gave intrauterine transfusion. A huge one. Managed to pull her through to the term, and then wonderful baby. I think I'll skip some of them because we don't have so much of time. I'll skip this one also. Okay, so this is one of the commonest scenarios. So this lady, again, this is about 10 years ago. This lady was asking, the previous baby was affected with a Down syndrome, had a 2 major cardiac surgery, is 11 years old. And she was asking me, why didn't you detect it earlier? I mean, retrospectively, all of us become intelligent. Prospectively, when you tell patients to do a screening test, they would think that we are doing all for money only. But once you have one abnormal baby in your life, it is, I mean, I don't need to explain the difficulties the patient, couple, family goes through is a horrible trauma. So this, how do we, there are wonderful screening programs now. We do NT, we look at the entry, we look at the tricuspid, we look at the ductus venosus, and you diagnose more than 95% of the Down syndromes, and day in and out, we may have to do invasive procedures. One of the invasive procedures is your chorionic villi sampling. This is done before 14 weeks. This carries a slightly increased risk of miscarriage and also a little bit painful procedure. You aspirate some of the chorionic tissue and send it for karyotyping. Rarely you may want to do some interventions to help obstetricians. This was when my wife was still practicing obstetrics. 2 o'clock in the morning, she called me that she got a unbooked case, a twin lady. One of the twin had a massive hydrocephalus, and she was in labor. So during cesarean section, to extract this huge head was difficult or deemed difficult. So she asked me whether I can help. So this was on the spot, my cortex worked. I said, okay, before you deliver this baby, I'm going to drain the ventricles and make the size of the head small. Anyway, this baby is severely moribund or dying, so or a severe morbid condition. So we could justify draining this one to help the mother. So we did put a needle into the ventricle and then drained before delivery. So my wife was very grateful. Very few occasions she will be grateful. So this is one of them. So how do we change the life of a neonatologist? One interesting case, again, this is a pleural effusion, bilateral pleural effusion. This one did not completely disappear. We managed to put a shunt. In this case, I could not get the shunt in the back. I managed to put the shunt only from the front. So this shunt was working, and she went into close to term, but the shunt got blocked. I think it was blocked. So she came to 36 weeks. Again, before delivering, my neonatologist was very unhappy that I'm delivering a 36-weeker in the night, and the chest is full of fluid. He asked me, can I help, or how can I help him? So I said, okay, under spinal, before doing a cesarean section, I'm going to drain this fluid so that at least when it comes to you, one headache is gone. So what we did, this is again a novel idea. Of course, it is described in the literature, but at that time I had not read any literature. This is out of desperation. This is how the fetal medicine interventions come out of desperation. So before doing a cesarean section, I managed to put the needle. One side the shunt was not working, so we drained that fluid. So the lung expanded before we did a cesarean section. This was nicer for neonatologist. And then I want you to watch this one. This baby pulled the shunt just before coming. Can you see that? Unbelievable what babies do. Because we managed to drain the pleural effusion, there was not much of trouble for the neonatologist. They did only to have to do get the airway rather than worrying about the pleural effusion. So maybe happy, right? So this was my last 1 or 2 slides. This is statistics 3 years ago. 3 years ago, yes, 3 years ago. In 5 years, I've done about 1,782 procedures. Now it is crossing just 3,000 procedures. All kinds of procedures we're doing, and some of them we lost. As I told, we do lose pregnancies. We got to understand the difficulties, and also our obstetricians and our colleagues need to understand the pregnancy loss rates. Otherwise, it is very difficult for a patient and for us also. So before I conclude, I want you to watch this video, and I'll stop. This is a massive polyhydramnios. We were draining because maternal discomfort was too much. So watch again. This is a baby. That's the nose. That's the lips. That's the eye. That's the lens. So this baby watching the needle, bringing the hand, pulling out the index finger, touching the sharp end, and moving it away. I wonder what these babies are capable of. In the dark environment, they can sense that there is some foreign body. Look at that. You can see the baby watching, bringing, looking at the sharp edge and touching it, coming it out. Unbelievable. So after doing all these things, you certainly believe Mahabharata and fetuses do amazing things. Thank you very much.
Amazing,
Correct.
sir. Amazing, Dr. Adi. It was really a treat to watch your videos, your babies responding to it, and the fetal reductions and the miracles you have created. It was
Thank you, ma'am.
amazing. I want to know, when we counsel a patient for fetal reduction,
Yeah.
Which would be the best time for you to do the fetal reduction? One thing. Second thing is the outcome and what we have to tell them regarding the outcome. We have before counseling a patient for fetal reduction. We all IVF specialists have that in mind. And what two important things you would want us to tell the patient?
Sure, ma'am. Answer to your first question, when is the best time to do? In terms of risk of miscarriage, it is much better you did it earlier. But there are two problems. One, how do you know if one of these babies are abnormal? And if it is abnormal, you might have stopped the normal one, kept the abnormal one. So that is a little bit painful condition. Number two is, if you did it early, some of the babies or some of the babies can disappear, or they can become vanished, or they may die. So you unnecessarily intervene. So there is no question or no logical proposition to do the fetal reduction before you assess the anatomy. Anatomy, you need at least 12 weeks. 12 weeks is a little bit too much. What I do is 11 weeks, 3 days or 4 days, because most of them are IVF pregnancies. Our gestation is clearly known. So by 11 weeks, 3 days of 11 weeks, 4 days, we can assess the heart also. That is the commonest abnormality and also difficult most. Apart from all other abnormalities, you particularly look for cardiac abnormalities. And if there are no cardiac abnormalities, then you can choose a baby which is technically easier to do it, which is away from the cervix. If it is abnormal, if one of the baby is abnormal, you selectively choose that one. So to make a valid fetal reduction proposition, it is much better we assess the anatomy first and then decide which baby to stop. So when answer to your second question, what is that you need to tell the patient? When higher order pregnancies beyond quadruplets, there is a clear-cut medical indication to do a fetal reduction. For a triplet, there is not a great evidence to say that we need to reduce medically, but socially, looking after 3 babies at a time, or the way I tell the patient, if you have to make all these babies join to a school, getting a seat in the school, 3 of them at a time is difficult. Even if you get a seat, you have to pay the school fees at a time. I mean, at least if you have 3 babies of a different age, then you can accumulate some money and pay the school fees. But if you have to pay all 3 at a time, it's a nightmare. So in our ecosystem, looking after 3 babies at a time is difficult. So there is a very good social indication to do a fetal reduction. So the way I counsel the patient, all babies, all triplets will get 3 options. One, doing nothing, continue triplet. The last one is stopping all the 3, which does not make any sense in an IVF setting. Continuing 3, most of them are not ready. So then you end up doing reduction of 1 and continuing twins. Now, what we have to look at it is the risk of losing a pregnancy if you didn't do anything. If you didn't do anything, even if you are a rich person, even if you are capable economically to look after 3 babies, many times you don't get 3 babies at home, take home. So 30 to 40% of the triplets would either have a miscarriage, preterm delivery, low birth weight, and neonatal stay, and so many problems. So only about 60 or 70% of them will have take-home babies with a triplet. So doing nothing and continuing triplets, one is difficult. Next, you don't get always, and the magnitude of complications is about 30 to 40%. So doing a procedure, continuing the twins, has got a better outcome compared to triplets. But procedure-related risk of miscarriage is anywhere between 1 to 3%. So it used to be 5% up to 10% in the past. Maybe because the number of cases we are doing is higher. Our current rate of losing a pregnancy is about 1.4%, but that is still a number. Now you need to understand the procedure-related risk of miscarriage, or the triplets are destined to miscarry. So is it because of the procedure? Is it because of the triplet? And some miscarriages happen at 18 weeks, 19 weeks, or later. Not all of them are attributable to the procedure. So anywhere between 1 to 3% is the risk of miscarriage, I quote.
Great, sir. Thank you so much. Any other questions? Very much, sir. Durgadas, sir. Sir, your input.
Yes. Dr. Adi, can you hear me?
Yes, sir.
My internet has improved after his wonderful talk.
Thank you, sir.
Dr. Adi,
Yes, sir.
2 years back, when we started ICOG, this KCOG,
Yes, sir.
I had a challenge to select 20 chairpersons of various committees. And for ultrasound, I did selective,
Sorry,
but
sir.
for whole year, everybody was blaming me. Where is your chairman for ultrasound? Not even a single session is conducted. I think today you have justified that why I picked up you as a chairperson of this ultrasound.
Congratulations, Adi.
Yeah.
I'm glad
Amazing.
you didn't kill
It's
me,
like
sir.
he
Yeah.
has, for 2 years, everything he has answered now.
Yeah, 2 years. He has answered
You
in
made
one
it for
session.
2 years.
And I was knowing a few years back, he came with one of my students and he had just arrived from foreign. They told he has started a program in People Tree Hospital. And in fact, I was looking for a good fetal reduction person. And you know that whenever I refer any patient, which procedure I am not knowing, I will go to that person whenever my patient goes. In fact, I went to Adi 2-3 times. I did find he's such a wonderful, the excellent surgeon for this. And his level of confidence, you just look at the videos where he's doing the procedure and look at his face. That whenever we are doing something difficult, our face will tell how confident we are. And he has done all this so confidently, and he has got wonderful series. I think he should come every month now because only 3 months are remaining for him. Every month, Vidya, you have to bring him so that he can add to our knowledge of ultrasound so much and perfection. Such a wonderful perfection. I don't think that he had no complication. Every procedure has got its own complication. And you know that the first case which I sent him pentoplate, that patient has brought me 6 more cases like this. And you can imagine how much the patients are happy. And I send the patient by Rani Channamma train. He does the procedure in the daytime. He sends the patient on the very same day in the night by Rani Channamma. Within 24 hours, they are in Hubli. Such is excellent post-operative procedures. And he has done many cases and amazing. Adi, you have really made a contribution to this intervention. I think today we all should look into this direction. How best we can save the babies which are inside utero. And I think this is going to be advanced. As he rightly said, in one of the procedure, he said, I am waiting for last 10 years, nothing has progressed. Adi, science is like that.
Yes, sir.
It will not progress for a number of years.
Yes, sir.
And all of a sudden you find in few, see, same thing was like this mobiles.
Yes,
We
sir.
had mobiles, you know.
Yes, sir.
And we started with a gazette which was showing the data which was in UK. And within 1 year in India, mobile came. And today there is no person without mobile.
Hmm.
So science is so advancing. I think these techniques which you have shown so wonderfully are really excellent.
Thank you.
Please continue to be a part of Kasoga and KCOG, and
Sure, sir.
definitely my selection to you by coming every month in the next 3 months at least. And last time when I sent him the patient, without contacting him, I sent the patient to Bangalore. And when I tried to contact him, his wife told me he is not well. He is not able to get up from the bed also. Then I requested some other colleague. I asked Pratima, please, patient is already in the Bangalore road. Can you do it today and send? Then she obliged it. Pratima did the case. She sent me back. I have got so much confidence on these two people, Dr. Pratima and Dr. Adi, that they are doing a wonderful work in our state. I think they are the pioneers for this. I think we all should go to them. We may not get, but definitely we should observe them, the way they have learned the art and the way they are exhibiting. And the so much of less than almost a 1% only complication is really great. In 100 patients, if you lose 1 or 2 abortion, nothing to worry. And normally also the abortion rate is so high.
Yes, sir.
And this procedure is not so high as a normal. And
Sir's net,
Last.
sir, net connection ಏನಾಯ್ತು? Anyway, any more questions?
ಸರ್ ಮ್ಯೂಟ್ ಆಗ್ಬಿಟ್ಟಿದೆ.
ಹಾ.
Mute ಆಗಿದ್ಯಾ?
ಮ್ಯೂಟ್ ಆಗಿದೆ ಸರ್ದು.
ಏ, ಇಲ್ಲ, ವಿಡಿಯೋನೇ ಹೊಟ್ಟೋಯ್ತು.
ಇಲ್ಲ ವಿಡಿಯೋ ಇದೆ, ಮ್ಯೂಟ್ ಆಗಿದೆ.
ಎಲ್ಲಿ
this
ವಿಡಿಯೋನೇ
is
ಇಲ್ಲ.
Mr. Arun's Kasoga's office laptop.
Okay.
Okay. All the best.
Okay, sir.
All the best. Thank you, Adi.
Thank you, sir. Thanks
Thank
for
you so
not
much,
killing me
Dr.
yet.
Adi. Thanks
All
for
the best. Thank you, Adi.
Thanks a lot. Yeah.
Sir, Irabet sir.
Vidya, you can continue.
No, Dr.
Vidya,
Adi
you
wants
can
to tell
continue.
something. Dr. Adi wants to tell something.
Sir,
Dr. Adi, please continue.
Irabet sir, thanks for not killing me.
Hello.
Anyway, it was so nice. Thanks for the beautiful deliberations, and I'm sure everybody has enjoyed.
Hello.
We look forward. Hiremat sir
Hello.
has already sent a verdict. I will call it a verdict that you have to come last months. You have to come every month.
Yes,
So
ma'am.
we look forward to see you in more and more programs.
Sure, madam.
Thanks a lot on behalf of KCOG and all Kasoga members. I extend
Pleasure.
my sincere thanks to you for
Thank you,
this
ma'am.
deliberation. Thank you very much and good night.
Thank you, ma'am.
Thank
Bye-bye.
you all. Adi, it was really a wonderful feast to the eyes.
Oh, very nice, ma'am.
It was like really you have got that expertise and the number speaks for it.
Thank
So
you,
we are
ma'am.
so happy to have you over here. Thank you so much. We will also be referring cases to you.
My
So
pleasure, ma'am. Thank you, ma'am.
thanks a lot for being in this platform.
Thank you, ma'am.
Thank you one and all.
Thank you. Thank you, everyone. Sir, Durgadas sir.
Adi,
Good night, sir.
good night. I am really proud of you. You are not only a bundle of knowledge. Your humble nature is such a attracting thing. See, today in fetal medicine, it's hard to get into your fellowship. Such
I
a
know,
big
sir.
competition that speaks for your knowledge and your knowledge. Add to that your simplicity. See, I am proud that you are hailing from Tumkur.
Yes, sir.
Really, I am proud of that.
All your blessings, sir.
Thank you, Adi. Thanks a lot for.
You delivered my sister.
I know.
remember.
I know.
He's also from Alma Mater, MMC.
Yes.
All the best, Adi.
Thank you, thank you, sir. Sir, Irabet sir, thanks for not killing me.
Thank you. Thank you.
I'll catch up soon whenever you want me, sir. Madam, call me anytime.